Okay. Well, good morning, everyone, and welcome to North Central Region Aging Network's monthly webinar, Engaging Seniors in Research, a series of studies aiming to optimize over-the-counter medication. My name is Christy Demitz, and I represent Michigan State University Extension as part of the North Central Region Aging Network. The members of the North Central Region Aging Network are extension professionals dedicated to improving the health and well-being of adults in later life through science-based strategies. So if you received today's invitation through a link from a colleague, we invite you to go to the NCRAN website and sign up to subscribe to the emails where you will get the invitation for upcoming webinars. So I'd like to introduce our speakers for today. And I'm really excited because they also represent Michigan State University. Dr. Alyssa Harbin is an academic specialist at Michigan State University's School of Packaging and part of Laura Bix's Hub Lab. She defended her doctoral research on the optimization of over-the-counter labels for older adults in February of 2021. Not an easy thing to do, Alyssa, during this challenging past year. And currently she's working in the areas of sustainability and healthcare packaging. And her co-presenter is Krishna Venkatesan, and he is a PhD student at Michigan State University's School of Packaging. He joined the Hub Lab in the summer of 2020 after successfully defending his master's thesis. He has a background in printing and packaging and is working on studies using eye tracking to examine over-the-counter labels. And Krishna and Alyssa, would you rather people wait until after the presentation to ask questions?
So we have planned for time at the end for questions, but we're comfortable if people have one that they've thought of in the middle that they don't want to forget. In between.
So if you can wait until the end of the presentation for your questions, you can also type them in the chat box if that's easier for you, and I will be watching that as well, as they will as well. So Alyssa and Krishna, you may start your presentation.
You're muted, Alyssa.
That's a common occurrence when I do Zoom meetings, but hopefully you're able to see the slides in the captioning today. We're talking about over-the-counter medication labels and how we've been engaging seniors in research to help optimize these labels for the older adult population. While Krishna and I are here today, we're not the whole team. We also have collaborators from psychology and our advisor and lead of our lab, Laura Bix from the School of Packaging. So we'd also like to acknowledge all of our collaborators, including Christy, who invited us here today, who's a key member of the recruitment team through MSU Extension, along with some other colleagues from MSU Extension, the Tri-County's Office on Aging, which is a Lansing-based aging support organization, and then other members of our lab and our pharmacy collaborators at Wisconsin. So today we're going to briefly introduce the field of packaging and the work that our lab does to work to optimize these labels and how we engage seniors in research. We'll talk about the studies that Krishna is going to be leading and that I led over the past couple of years, and talk about some of the challenges and opportunities we faced working with older adults in the community. So first, what is packaging? Lots of people, when they hear about the that we study packaging or that have a doctorate in packaging, it takes them like a second, and then they realize every single package they've ever interacted with their life, and that someone at some point designed it, and that there is planning and science behind that. And then they realize, oh, this is something that's everywhere and really important. But packaging is a multidisciplinary field that includes the humanities when we look at history and consumer behavior, and it includes social sciences with applied psychology, and it includes businesses and value chain with looking at supply chain and logistics, and also it includes the hard sciences like chemistry and physics and material science, and combines all of these fields together to really optimize getting the products that people need and want available for them to use in their homes or workplaces. Our work specifically within packaging is in the area of user-centered design and figuring out how to switch from a product-centered design framework, which is all about a product and making sure that the product can perform, to a user-centered framework that really focuses on the person who's going to be opening the package and using the product, and focusing on making it easy for the user to figure out information they need about how to open or use a product. And we do that by involving users in our research to assess the efficacy of different design strategies. So our whole lab is designed around trying to make medical packaging go from product-centered design exclusively to a user-centered framework that includes key stakeholders who use medical products, one of which are older adults. So over-the-counter medication is very popular. In 2017, the most up-to-date data I've seen, almost $35 billion worth of over-the-counters were sold in the United States. 93% of adults prefer to treat minor ailments with an over-the-counter medication, and 86% of adults believe over-the-counters reduce the cost of healthcare for people like them. And one group in particular that uses over-the-counter medication more than others is older adults, who make up about 15% of the population, but consume 30% of all over-the-counter drugs. So this is a group that is disproportionately representing a share in the marketplace for these types of products, but isn't currently being reflected and cared for in a status quo of labeling. There's very few labels that include age-specific warnings, even though there are many medications that have different risks for people of older ages. And those risks are adverse drug reactions. Adverse drug reactions are more common than we might assume, as many of us are probably non-healthcare providers. Worldwide, between 3.2 to 5.8% of all hospitalizations of older adults are related to adverse drug reactions, and self-medication with over-the-counters is implicated in about 4% of those. So that doesn't sound like that many, but it is the number is in the hundreds of thousands a year. So it is quite a few lives that are impacted. In age, polypharmacy, or using 5 or more medications a day, and health literacy are all linked to increased risks of suffering an adverse drug reaction. And the label is one thing that can help the consumer make a choice that can help avoid a preventable adverse drug reaction. And so while information alone is not enough to make sure that all of these reactions are avoided, it is necessary to avoid many of the adverse drug reactions that are occurring, and really looking at the labels and assessing how we're communicating risk to people who are consuming these products is a key function of packaging in providing consumer safety. So I'm going to turn it over to Krishna to talk a little bit about some previous work our lab has done.
Can you guys hear me?
We can hear you, and I think everybody's keeping their video off, so maybe it'll make the internet connection more stable.
Thank you. Thank you, Alyssa. And from Alyssa's presentation, we know that adverse drug reaction is a serious issue, and it's a huge problem, especially for older adults. And we also know that we, as packaging professionals and packaging designers, can do something to help. But how can we do something to help? This is where user-centric packaging design comes into play. So on your slide here, you see what we call a human packaging interaction model. And this is what we typically expect a consumer to do when they are exposed to a package. So when they come in contact with a package, they are exposed to the information in the package, which is the first stage. And once they're exposed to the information, they perceive the information. By that, I mean the brain uses its sensory organs to get the information that it needs. And after that, the brain encodes this information. So by that, the brain basically takes all the information from the sensory organs and puts it into its own mental image. And after the brain has a complete picture, it can comprehend the information, which is basically it trying to understand what the information is using prior experience and knowledge. And once the knowledge is available to use, the user can choose whether or not to execute the information, i.e. they can choose whether or not to act on the information. So why is this relevant to older adults and adverse drug reactions? So imagine the scenario. So if we could design a package that could potentially convey the information to the consumers in an effective manner so that they have the information to act on it, then we can reduce the effect of adverse drug reactions and the risk involved to senior adults. And before we actually go about designing a package that is good at delivering that information, we want to make sure if the existing packaging formats and packaging designs are very good at doing that. For that, let's take a look at some of our lab's previous work. So in this slide, you're looking at Lanching Liu's work, who is a fellow researcher in the Packaging Hub lab. So what Lanching was interested in was looking at the effect of the delivery efficiency of drug information delivery of different available packaging designs. So what he did was he took 3 different drug categories and tested 3 different active ingredients, so which is a total of 9 drugs. And then he tested 3 different levels of formatting for the 9 different drugs, which is a total of 27 trials. So he tested this information on 82 participants, 56 of which were female and 26 of which were males. And all of them were 65 or older. So the participants would come in and then they would look at each of these 27 trials or packages, and they would decide whether or not the drug was appropriate for them to use based on the information that's available in the package. So let's take a look at the results in the next slide. So in this slide, you see the information, the data that we collected as a part of that study. So here we see the number of subjects that turned beyond the PDP. So the PDP is a principal display panel and the front panel of a package, and which is it's also the most prominent side of the package. And so we see like how many people turned beyond the PDP for how many number of the trials which they conducted. So we see that only 27 of the 82 participants turned beyond the PDP into the drug facts panel, which is the panel that contains the warning information for all of the 27 trials, which is a very small percentage. And we see that none of them turned, about 62% of the participants did not turn beyond the PDP into the drug facts panel for any of the trials, which means they did not look into the drug facts panel for any of the packages. So why is this relevant? This is relevant because if you remember the human packaging interaction model, for a person or a consumer to get the information that they need, to comprehend the information that they need, they should be exposed to the information. So if they never turn beyond the PDP into the drug facts label, which has the warning information that helps them make a decision, they can never actually have the information because they are never exposed to the information. So we see that the human packaging interaction model is failing for current medical packaging labels, which are available. But we can also see that in the decisions that the participants made in the next slide. So in this slide, we see decision pairs that have been represented in this chart here. So what happened was the participants would make a decision after looking at each of the packages, and they would say whether or not a drug was appropriate for them based on their medical condition. And after that, a pharmacist would also make the same decision for that participant based on their medical condition. So that was a more well-informed decision made by the pharmacist. So you see the first part of the pair is the decision made by the participant, and it's followed by the decision made for that participant by an actual pharmacist. So we see if both of these decisions are the same, then the pharmacist and the user are in the same page. They don't have any discrepancy. But then if these two are different, that means the pharmacist and the consumer do not have the same understanding of whether or not a drug is appropriate for them. One such pair is a yes-no combination, which is when the participant thinks a drug is appropriate for them, when the pharmacist thinks that the drug is actually not appropriate for them because of the medical conditions. So you can see that a whopping 17% of the trials had this combination, which puts them at a very high risk for adverse drug reactions, because if a participant thinks that an inappropriate drug is actually appropriate for them, they are more likely to purchase the drug and then consume it, which would put them at a higher risk for adverse drug reactions. Let's take a look at the next slide to see how we can design a better package. So the data that we saw from launching Loosewalk clearly tells us that the current packaging formats are not effective at conveying information to the participants. So how do we improve this packaging labeling system to make it more efficient to deliver the required information to the participant, even when they're not actively looking for it? So this is when we take a look at the literature and we find out that there is a formatting label called the front of pack labeling strategy, which has previously been proven effective to garner attention and convey information to the participants. So what is a front of pack label? A front of pack label is when we take critical information from the drug facts label. The drug facts label, again, is the panel of the drug package, which has the warning information. So we take some critical information from the drug facts label and we put in the front panel, which is the PDP, or the principal display panel. So the idea is that since the principal display panel is something that everybody looks at as a consumer, putting some critical information in that panel would perhaps deliver information faster and would probably prompt them to take a look into the drug facts panel, which would get them the whole picture and make a better decision. With that, I'll let Alyssa talk about how we used front of pack labeling and how we came up with a research study to test the efficiency of front of pack labeling in our study.
All right, thank you, Krishna. So what we're talking about today is a series of studies that are engaging pharmacists and older adults that are out in the general community in assessing whether or not this front of pack labeling strategy and a highlight labeling strategy is effective at communicating critical information and improving upon the existing drug facts label schema for communicating risks. So the first study was conducted by our partners at Madison, or at University of Wisconsin-Madison, where they did a survey of pharmacists to look at what type of information pharmacists would say should be prioritized at point of purchase and then at point of use. And then I conducted work in support of AIM-2 and AIM-3 to investigate formatting techniques that attract attention. So our FOP, our front of pack, and our highlighting to see how those garner attention and if they garner more attention than the standard labels. And then also if those formatting techniques help improve the use of that information. So it doesn't make it easier for our participants to answer questions about the labels if we provide highlighting in a front of pack label in addition to the base information that they all have. And then Krishna is taking over and will be in charge of leading AIMS 4 through 6, looking at some eye tracking work to further assess this information and how seniors are using these labels later on. And he'll talk about that after I cover the first bit. So we looked at 4 different labels, and those 4 labels were a standard label with a mock brand name, but real drug facts information and a real active ingredient. And that label was designed to mimic what might be sold in a store today. Then we added highlighting to highlight the active ingredient information and some critical warnings that could help prevent an inappropriate purchase of a medication. And then we also added that front of pack label where we moved the information that was highlighted also to the front and made it so that if people were only looking at the front, they could still access that information. And then finally, we combined those 2 strategies by looking at highlighting and a front of pack label. And so this is basically the benchmarking studies that I was leading to assess how much attention is garnered by these different treatments and also how they facilitate use of information. So for these studies, we recruited older adults who were consumers of over-the-counter medication, defined as using it at least once in the last year. An older adult was defined as 65 years or older, who were legally cited so that they could visually interact with the labels, purchase and manage their own medication, and were willing and able to travel to the testing locations. Our testing locations were throughout the state of Michigan. We had some in the Lansing area, some in the Flint area, and some in the Grand Rapids area. So participants were able to schedule appointments that were closer to them. We were working on getting some in the Detroit area, but for most of these studies, we were not able to recruit in that area. And then also for the change detection study, which looked at the noticeability of different pieces of information, we had one more requirement of no history of seizures or epilepsy due to the way that the study flashes a trial in front of them on the computer. So we were looking for older adults who are diverse in race and gender and educational background and socioeconomic status. And that was one of the big reasons why we went out to these different recruitment sites across the state of Michigan to try to get people that weren't necessarily affiliated with the university as like an emeritus professor status. That's one challenge that we have recruiting on campus. So I'm going to show you an example of a change detection trial that the older adult participants would have been asked to complete. I did want to warn you that the slide will flash. So if you don't want to look at a flashing slide, I will also tell you once it's over so that you can look back at your screen. So here we go. So this is an example trial that the older adult participants would have completed, where they would have been tasked with finding one change that was occurring between the 2 images. And you can see that there's a blank gray screen in between, and that induces change blindness and makes it so that this is a measure of how noticeable that piece of information that is changing is by looking at the accuracy and the reaction time that it takes for people to find that change. So on this slide, in this example, what is changing is the highlighting on the active ingredient on the front. It is appearing and disappearing. And so that's an example of looking to see how noticeable is that highlighting. And again, we measured how long it took people to find a change and if they were accurate in assessing where the change was happening. And so for this, we had 60 participants, and I don't have time to go through all of our analyses for all of these studies, but I did want to share some of the results. And so for this one, I'm talking about active ingredient trial results. So similar to the trial that you just saw. For these, we found that highlighting was very helpful in helping people find the information that was changing, especially when we look at the accuracy. In the drug facts label, the active ingredient information is pretty small, which is actually one of the reasons when we did focus groups, older adults talked about not using it. It was because it was so small, it wasn't easy for them to use. They often said, I would need a magnifying glass in the store to use that information. And so we know that that's a widely held belief. But this highlighting of that active ingredient in the drug facts label improved the accuracy of that information and finding that information to a level that was not significantly different from the big information on the front of the package in the principal display panel. So we saw a significant improvement there in the accuracy of finding that information in the drug facts label. And then we also found in the reaction time analysis that the highlighting was still helpful and that the front of pack label was garnering some attention. And that was evident in a slowdown in trials that featured the front of pack label. People were spending some time looking at that information, and then it took them longer to find the change that wasn't there. So that label was garnering some attention and people were spending some time looking at it, which was a good sign that it would be something that people noticed, read, and comprehended in our later studies. So then moving on into aim 3 from the previous slides, looking at how do these labels help people use the information, because if it's noticeable, that's excellent and that's prerequisite for using it. But if it's noticeable but people can't actually understand what it means and what type of information it is, that doesn't really help solve the problem. It just makes the problem more noticeable. So here we're looking at, do these formats help people use the information? So we didn't change any of the wording between the trials. We looked at the same labels as before. We just had the 4 label treatments. And in this study, we asked them yes or no questions about the medicine label. And they responded on the computer by pressing Z for no or M for yes. And we had 75 participants recruited for this with, I believe, about 60 included, or 70 included in the analysis. And for this, the results I'm going to briefly cover were the drug warning label results. And for these types of questions where it was a yes/no question about the label, we found that accuracy, when we were asking them yes/no questions about a drug warning, was significantly improved in a highlighted front of pack label compared to the standard practice. So making that information easier to find made it so that people were significantly more accurate in answering their question, which is a good sign that not only did the information help them find it, but it also helped them use it. By making it easier to find, they're able to more efficiently process it and use it to answer that question because they were able to identify the correct information in the label that would help them. And we also saw in reaction time that highlighting was again beneficial with significantly faster results in the standard highlighted label compared to the standard practice label. So we're seeing again that the highlighting and the front of pack label are helping people find this information and use it in a question about the medication, and significantly improving their performance when these labels are present. So this is again a good sign that based off of the human package interaction model, that in the previous study, we were seeing that the highlighting was helping people notice or perceive that information. And here we're seeing that that process is continuing, and that because they noticed it and were able to perceive it, they're able to comprehend it and execute the correct response in a trial based off of that. And so then the final experiment that I conducted was looking at a different type of task, and that was comparing between 2 products. And this is important because oftentimes when we're experiencing a symptom and we go to the store to buy medication, we might consider multiple alternatives. And so we need to be able to easily compare those alternatives to see if they treat our symptoms, if they have different levels of warnings, that type of information. And then also when we're examining medication products that we might have in our drug cabinet at home, and we're experiencing symptoms, we need to make sure that we're choosing the right type of medication again. So this is also a common task that people do. They don't just look at one product in isolation. Oftentimes we're considering multiple alternatives. So we wanted to see if our labels helped with this type of task. And our preliminary results are that yes, the highlighting did significantly speed up the amount of time that it took for people to make these types of decisions. These results are preliminary because COVID-19 made it unsafe to finish data collection with our older adult participants in person. So we did analysis based off of the first 2/3 of the data, but eventually this data will be finished, and that'll be once it is safe for us to do so. But what we were able to find is overall people were very, very accurate, and there were no significant differences in accuracy. I think when people are looking at two types of information, and they're a lot more easily able to figure out which information affirms the question and which one is the correct response, rather than the previous task where they were looking for the absence of information for a no response question. But we did see that the highlighting did significantly improve reaction time, which means people were able to more efficiently make these decisions, which is likely a big factor in whether or not people are willing to really think about their over-the-counter medication products. Is if it's easy to quickly figure out which one's safe for you, people are more likely to be willing to do that cognitive process rather than skipping it because you feel like you need a medical degree to understand the label and make a choice. So the big takeaway so far is that highlighting in the front of pack label helped garner attention to those critical pieces of information on the over-the-counter drug label that are relevant for older adults, and that these formats are worth examining in real brands and in real types of decision making, which by that I mean people making a decision about their own health and whether or not they should use it moving forward. So now I'm going to turn it back over to Krishna, and he'll talk about what's happening next.
Thank you, Alyssa. So from Alyssa's study, we know that the participants can detect a change in the front of the label, on the front of pack label with highlighting. So even when they're not looking for it, so even when their task is not looking for such an information, they are able to find it, which means the information is prominent. After that, we also know that the participants were able to make decisions, or more accurately, they were able to fetch and understand and use that to answer the question when that is their task to do so. But then what we are looking for is, are the participants actually able to use this information from the package to make a drug appropriateness decision? So if we also want to know if the participants can actually make a decision get the information from the package and make a decision on the appropriateness of the drug. So we want to make a study that would test such a thing. And we also want to know if the participant actually got the information from the package, and if they got it from the package, which part of the package did they get it from. And so for that, let's take a look at eye tracking. So eye tracking is a tool that helps us determine the point of gaze. So the point of gaze is basically a point in space which your eye is looking at. So what the eye tracking does is it uses a camera and a software integration to look at your eye, to be more accurate, the colored part of your eye, which is the iris, and it comes up with an estimation for which point in space you're looking at. So typically in an eye tracking experiment, so the participant's head is kept immobile, it's kept unmovable. It's fixed in a point of space, so that you have to move your eyes to look at different points of a display. And you can see a basic picture of like a person doing that on the picture here. So let's take a look at how eye tracking would look in our experiment. So you see here, so this is how it's going to work. A participant would come into the testing site. They would be seated in front of a display, which you see on the left side. And the display is going to, the monitor is going to display stimulus, which is the package. And the package is going to be in digital format, but then it is a two-dimensional representation of a three-dimensional package. So, and packages are usually in the shape of a box, and we know a box has 6 sides. So the participant is free to move between the different sides of the package whenever they feel like it. And after they've looked at the information that they think is necessary to make a decision on the product, they can press like a button to tell them about the decision. While they do this, we also track their movements of the of their eye to look, get a good picture of which part of the display are they looking at, so which information they're looking at, and we use that in the data analysis. And also, we compare, similar to like launching loose work, we are going to compare the participant's decisions with the decisions made by a pharmacist for that participant. So let's take a look at the stimulus, and this is how a stimulus would look for this study. So you see on the top, we have the research question, which is if you had the condition that this drug treats, would it be appropriate for you to take? So in this case, the drug is ibuprofen. So if you had, like, let's say body pain and ibuprofen treats body pain, would it be appropriate for you to take ibuprofen based on your medical conditions? So the participant would use the navigation panel in the bottom. You can see they can switch, so they can press any of these buttons in the bottom to switch between the different sides of the package. You can see the drug facts label, the PDP, all available in the bottom. So after looking at the package, they can either press the yes button on the left or the no button on the right to make the decision. So if I think I can take ibuprofen because my medical conditions don't have a contraindication for me taking ibuprofen, I would say yes. Otherwise, I would say no. So you see, you might have noticed something in this study. You might have noticed that this, like the pictures or the packages that we test do not have a lot of color. They don't have, a good amount of artistic rendering or designs. So why was that? That was because in a scientific setting, we try to reduce the amount of variables that there are in a study. So to get the information that we need without any noise, as we call it, in the data, we have to make sure we keep most of the things similar and reduce the variability so that we can get the answer to a research question. But then this doesn't always translate to the real world, does it? So that means we would have to test to see if a real world condition actually works for the strategy that we came up with, which is the FOP, or the front of pack labeling strategy. So the next study, which is the study after the one that I just talked about, is going to be testing this. So we know that the FOP label can garner attention, but real life labels do have other things like bright colors. They have attractive fonts and other like things like graphics and even photos sometimes, like pictures of faces and logo designs. So those things would distract the user from the FOP label. And we want to see if, despite all these distractions, does the FOP still deliver the information efficiently and accurately to the user. So let's take a look at the study. So the study is going to be pretty similar to the previous one, except for the fact that the stimulus is going to be a real brand, slightly modified to be a front of pack label. So you see here, in this case, the research question is the same, the navigation panel is the same, and the decision buttons are the same. The only difference is the middle part, which is the actual package. So you see this is an actual brand, which is available in the stores. However, this is not exactly the same graphics. We came up with this graphics, we designed it, and we modified it to accommodate the front of pack label, which you see in the bottom right corner. We also see that the highlighting has been done in this particular sample. So let's take a look at examples of some of those stimuli that we would see in such study. So these are the few things that we have come up with for the study, and you can probably ask stimuli for of a study. With that, I'd let Alyssa take over about community engagement and the problems we've been facing with recruitment of participants. Thank you.
Thanks, Krishna. So we're going to wrap up today by talking about both the benefits and challenges that we've experienced working with the community. We'll start on the positive side and talk about those benefits. And one of the things that our lab has a lot of experience with in the past has been meeting with stakeholders who are able to make change happen in like the regulatory world or in consumer brand and brand owners. But one of the challenges in convincing those stakeholders to make decisions is having enough data that shows that there is something wrong that is in need of fixing. And that's where working and collecting data with people in the community really comes into play. It helps build that amount of information that then convinces the stakeholders to make a change. And so far we've seen a couple big benefits of working directly with the community, and that is that participants get to be involved in the process of improving product packaging systems by contributing their data and their experience to potentially making a change happen. Also, when that data is more representative of diverse life experiences, it builds a stronger case to the need for improvement. And working directly in the community in many areas across the state of Michigan helps us to have that more representative sample than if we were only working with university affiliated participants, as most of the people that are affiliated with the university in this older age group tend to be retired professors, and that sample is not really diverse in the amount of education that they've received. So that can be a challenge there. And then also another big benefit is that non-scientists get to experience science in action and learn about the process of developing new knowledge and better understand how small studies all come together to build more knowledge. And that helps develop a little bit more trust in the scientific process if people are able to experience being a part of a study. We've noticed a lot of positive feedback from participants who are maybe doing it for the first time or 100th time, in that they really enjoy being a part of the scientific process, even if they're not scientists in their day-to-day jobs. So along with those benefits, we've also experienced many challenges. And a couple of those are with recruiting. While getting that diverse representative sample is the goal, as it helps create a more compelling case for change to be made, it is difficult to recruit diverse groups of participants, as a lot of our partners have very specific groups that they work with and are targeted programs for. So we have to build lots of different relationships with different community organizations, and MSU Extension has been very helpful in that, working with some health and aging and exercise classes to recruit participants. Our partners in Flint were promoting it at some gardening classes, so people with different types of interest. And then in Lansing, we were able to go to a lot of community centers in different areas in the Lansing, different communities in the Lansing area, and reach some of the people who are involved in those senior centers. And that has been helpful, along with recruiting seniors who volunteer in local public schools. But it's still difficult to get that diverse group, especially because it's really difficult to recruit men. I don't know if you've experienced a hesitancy of men to sign up for and participate in programs that you are sponsoring, but we've noticed it is very difficult for us to get men to sign up to participate in these experiments. A lot of the men that we do get to sign up were brought along by a family member, such as like a wife or a sister who was engaged and thought it was a good opportunity and had someone to bring along with them. And one of the reasons our participants are likely to do that is we do pay them. For these experiments, we pay our participants $50 for their time, and that can be a significant amount of extra money to get in a relatively short amount of time. So people like to share that experience with their loved ones. But along with that money, there's a challenge of overcoming seniors' fear of getting scammed. So one thing that we've noticed is that the programming that lots of senior centers, including I believe some MSU extension centers, have been doing on teaching seniors to avoid scams have been working really well. And we get a lot of phone calls from people who are interested, but are trying to do their due diligence to make sure that we're not going to scam them and that we're a legit lab that's affiliated with MSU University. So building that trust and making sure that the seniors feel comfortable coming to participate with us and sharing their data by participating in the study, we have to make sure that we are building a relationship of trust and are open and answering any questions that they might have. And then the final big challenge, or two challenges, is making the participation process directly beneficial or educational to the participant. Right now, it's a pretty one-way street where we get information from them and data, and we thank them with their participation incentive, but it's not yet a part of the process to make it an educational experience or a beneficial experience in terms of knowledge gain. And that's something that we're working on and thinking about how we can make this a little bit more of a two-way interaction where we both share. And one of the things that we've been doing in this area is preparing presentations for the senior centers that we recruit at to talk about the work we're doing in child-resistant closures and other types of packaging and labeling around medications that wouldn't directly influence their responses in this study, but could help provide information that is useful for them in other areas of their life. But part of the COVID-19 pandemic has been making all of those sites more of a meal pickup and drop off location rather than a communal lunch. And so we haven't really been able to make those presentations and have this process be more of a two-way street. So that's one of the challenges, along with sharing results with participants who are interested in learning what we learned. It can be difficult to communicate those to the participants in a timely manner. And another big thing is our studies are computer-based, and a lot of our participants express apprehension about doing a computer-based study because they don't feel comfortable or confident on a computer. And so that's something that we need to coach and teach them and be there as a supportive research assistant to make sure that they are comfortable with the process. But that's been a challenge as we haven't been able to convert to online studies during the pandemic because there is that technology barrier. So those are some of the challenges we faced, but the benefits are definitely worth the efforts to try to overcome these challenges. But with that, I'd like to wrap up and say thank you for listening and your time, and open it up for any questions that you might have about our work and how we go out in the community and do this research with older adults or anything like that.
Thank you so much, both Krishna and Alyssa, for coming to us today. I was part of this study in that I helped to recruit some participants in our one of our areas in Michigan. And for those of you that aren't from Michigan, a lot of the cities or areas that they talked about are more urban areas, and we call it lower Michigan, and then there was an upper peninsula and upper Michigan. So they are in the more populated areas in Michigan. What questions do people have for Alyssa or Krishna? So our colleague Chelsea says, thanks for sharing the limitations with recruitment. They're going to start a project and foresee some similar issues.
Yeah, so any advice on that project that I could give you is to start building those connections early with potential places that serve populations that you think might be hard to reach. So one of the things we've been working on is trying to figure out how to recruit in some like veterans organizations for older adults, as a lot of the people in those organizations are men. And so it's a way to reach more men without necessarily only recruiting men. And so working on finding out those opportunities and building relationships early has been really helpful for us. So if that's helpful for you, I hope it makes your recruitment process easier. If not, you can ignore my advice.
I'm sure that will be very helpful. As people are thinking of other questions, I just wanted to ask people if they would, before they log off, to complete the survey that was put in the chat box before you leave. So there's another question. Is there a plan to make those studies virtual for older adults to participate in the future? And if so, how will it be similar or different from the in-person study?
So these studies themselves are not going to be converted to a virtual format, primarily because the eye tracker is an expensive piece of equipment that is very precise. So we need to have them use our equipment. But our lab is working on other studies, specifically looking at over-the-counter medication and e-commerce. So people who are buying their medicines now on Amazon and getting them shipped to their house, and looking at how that information is being presented, what information might not be prioritized in those thumbnail pictures that people see before they buy the product. And I know we have a lab member who is, thank at the beginning, Hao Yang Wang, who's looking at that area and trying to develop a virtual study where they can collect that data and help make the more knowledge about how e-commerce is doing in this specific area where there can be big health risks involved, but we just don't know enough because it's so new. So there is plans for some similar work, but not our specific work.
So one more thing I would like to add on top of Alyssa's answer is that, so a lot of these studies that we do depend a lot on the size of the stimulus that we use. So, and the size of the stimulus usually depends on the screen size. So if it's a monitor, and then, so if we send it virtually to the participants, so you might have a 13-inch monitor, and then someone else might have a 32-inch monitor. And there's a huge difference between a small monitor and a big monitor when it comes to like testing conspicuousness and the saliency of a package. So if it's smaller, it might be less like conspicuous, and it might not stand out as much. And that's something that is a variability in the study, which we would like to avoid. And that's usually why we bring our own monitors into the testing sites and then let the people test in the same monitor. So one more thing, even though we don't use color in most of our studies, again, is like monitor calibration. So you might not be actually aware, but like, so, and we might just like get this over the top of our head like half the time. So the thing is, like, monitors like are not always calibrated in the same condition. So like the red that you see in one monitor might not exactly be the same shade of red in another monitor. So, and that again could create a variability, and like there are like certain factors that kind of limit our potential. So so if it's a study that it's like this, we usually like to keep it in person for those reasons, and on top of what Alyssa said.
Yeah, I never thought about that. Thank you for sharing that. So as you were going through your presentation, I'm thinking, this seems like such a no-brainer. Why wouldn't people want to do this? So can you talk, I know you talked about having the data to prove that, you know, the design would be warranted, but can you talk a little bit about why people just wouldn't automatically do this?
Yes, so a big thing is brand owners want people to recognize their brand and they really prioritize that information over stuff that might limit sales if people recognize, oh, this might be dangerous. So there is both convincing people that safety is more important than maybe a couple additional sales each month. So there's that hurdle. And then also one of the things I learned while I was doing background research in this area was that when the FDA first established the drug facts label in the 90s, they actually tested looking at highlighting and decided that based off of mall intercept studies where people didn't really have that much of an opinion about that difference, that they wanted to make the simplest requirement possible. Since then, there have been some changes because they've realized that that highlighting really is important at calling out information. If you've bought Tylenol in the past 10 years or so, you've probably noticed that Tylenol now has highlighting on many of the labels because the liver damage risk is so high. So the FDA has kind of backtracked a little on not requiring highlighting to require it for two types of drugs, NSAIDs, so like ibuprofen, naproxen, other non-steroidal anti-inflammatories, and Tylenol, because they have a greater risk for more people. But our work here has kind of shown that the benefits are there for all different types of drug categories. So if we're going to require it for some, maybe we could require it for all of them to make that piece of information really stand out. So there is some drugs that are highlighted, but I think all of the active ingredients should be highlighted. And I think that's kind of like the floor, for my opinion, in making sure that everyone has the greatest chance of looking at that information. Because we also found that people are really familiar with brands, but not as familiar with active ingredients. And trying to prioritize that safety information can help them become more familiar and hopefully help them make more informed decisions, because the labels are there to help consumers be confident that they're making a healthy choice and make that healthy choice. And we need to make sure we're doing our part on the labeling side.
Yeah, for sure. So we're coming to the end of our time together. There is one more question, but if you have to leave, we understand that. But please, before you leave, to complete the end of webinar survey. But either Krishna or Alyssa, can you address how you're advertising the need for study participants to the older adults? Talk a little bit more about that.
I think actually you might be the person to answer that question, as you've been doing a lot of that work yourself. And I basically do the same thing that you do, where we present the opportunity and pass out flyers, but you might talk a little bit about how you've targeted some programs specifically.
Yeah, we really tried to target for diversity because we knew how important that was. So we relied on a lot of our partners, and all cooperative extensions have lots of community partners, and those partners in our areas that provide services to older adults. So whether it be an area agency on aging or another agency that provides services for older adults, it was really pretty almost seamless because we had those connections in the community. So if somebody they didn't have those types of connections already established, I think, Alyssa, what you said, to start early and start building some of those connections before you have to start recruiting would be essential. But they distributed the information at mealtime, they distributed information during exercise programs, they emailed it, they put it in print newsletters. So it went out in a lot of different ways. But I thought that, at least in our area, we got a nice mix of participants for a couple of the phases of the study.
Yeah, and to add to that, I did a lot of going to senior centers and having lunch with older adults to kind of put a face to the study in the Lansing area. There is about a month where, like, once a week I was going to a different senior center. So I did a lot of word of mouth recruiting here too, to try to start building those connections with the specific sites rather than the area agency on aging's leadership. We tried to build a bridge to those individual locations too. So a lot of hand passing out of flyers at those events too.
Yeah, that's a great point. And also to that point is that those partners already have relationships with a lot of the older adults. And so when they know, MSU Extension, and we have a relationship, but when the partner promotes it to the people that they're serving, the older adults trust that partner. For example, the Area Agency on Aging. So there's a little less hesitancy of, versus seeing something in a newspaper asking for participants. When it comes from a trusted source, I think it's a little bit easier sell too. So putting a face with an ask and also having that already trusted partner in the community to help recruit participants. Oh, well, Krishna and Alyssa, thank you so much. It's been a wonderful webinar, and want to invite everybody to come back next month on May 7th. We have a monthly webinar, and it's on 5 flavors, how the palate changes. That sounds very, very interesting. So we hope that you can join us for that one.
Thanks for having us, Christy.
Okay.
And thank you everyone for your attention.
Thank you all.